Good afternoon and welcome to our oncology lecture series. I am Dr. Khaled Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be the moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Doured Daghistani. His presentation is titled Up to Date in Pediatric Hematology Oncology. Dr. Daghistani is a Chief Pediatric Hematology and Oncology at Baptist Health Miami Cancer Institute. He's a board certified in pediatrics with a subspecialty in pediatric hematology and oncology. Dr. Daghistani received his medical degree from the University of Damascus in Syria and completed an internship at the Mosa Hospital in Syria and at the Hospital Center of Mamers in France. Then he completed a residency in pediatrics and a fellowship in pediatrics hematology oncology, both at the University of Miami Jackson Memorial Hospital in Miami, Florida. In October 2015, Dr. Daghistani was named president of the medical staff at Baptist Health Hospital after serving a 4-year term as a vice president. Dr. Daghistani is a member of several professional organizations, including the American Academy of Pediatrics, American Society of Clinical Oncology, and American Medical Society of Hematology. Our esteemed colleague speaks, of course, Arabic, French, and English, and he is a very well renowned speaker nationally and internationally. With that, please let's give a warm welcome to Dr. Doured Daghistani. Dr. Daghistani, what a pleasure seeing you again. Thank you so very much for joining us today. You may go ahead and present your slides.
Thanks, Dr. Hakim, for this generous presentation. And I would like to welcome everybody here who's joining us, and I hope you will enjoy and learn. And I start with the word enjoy first before learning, because if you don't enjoy, you're going to go to sleep in 5 minutes. So, yes, when I was asked to prepare the talk, I said, what kind of audience I have, and I was told the audience is going to be a mixed audience. So I'm going to make sure that I really update you on mainly oncology and a little bit of hematology. And to me, I think I'm a very veteran. I came to Miami in 1982, and I've been practicing pediatric hematology oncology since 1986. And I think mainly the oncology field has been probably the most field that showed advancement in a very speedy way that it's just incredible. When I started, just to give you an example, I'm a 68-year-old. I was 7-year-old when I saw a movie in Damascus in 1965 where a family took a child to the doctor. The doctor said, hey, I'm sorry, he has acute leukemia. You have 6 months to enjoy with the child. I can't do anything for him. And now I moved to the state, 1983, 84. At that time, acute leukemia in pediatric was 50% survival. So I felt very good. I have 50% chance on saving your child. And you go forward 35 years, I'm sitting now with the family, I say I have 90% chance of saving your child. So how did we come around in 30, 35 years from saying we can't do anything to save them? And that's what I want to share with you. And I'm going to go to my next slide. And I want to give you a little bit of historical perspective. How did we get here? And in the 80s, there was an amazing things happen. I called it the molecular biology revolution. And this is where PhDs and MDs get in the lab and they started taking small pieces of DNA and RNA and populate them. And I remember it was the HIV era at that time. We had children where we didn't know what's wrong with them. And if all of a sudden we have HIV, we started using Western blood to diagnose HIV. But then this was very important because you can take a gene and you can populate that gene and study it. And then we go to the 90s, although I'm not a Democrat in this country, but it was during Bill Clinton era where he signed a contract with the NIH to map the human genome. Imagine in 1990, we didn't know what is the genes in the body and what is the complexity. So it took NIH maybe around, I don't know, 8 years, 10 years between doing the mapping and the sequencing. And it's hundreds of millions of dollars all over the years. But then we had the sequencing. And the technology got so good right now, we can sequence and we can do a study on the gene. It probably doesn't cost $2,000 and we can get the result within a couple of days. So because of all these advancements, we were able to look to the cancer from different perspective. In the 80s, when I was treating acute leukemia in children, it was very well known that this leukemic cell has dozens and dozens of abnormal chromosomes. We don't know what does it mean, but now we know what are these chromosomes, if they have a bad influence or a good influence. And because of that, in the early 2000s, we started looking into what I call them second, third, and fourth generation of chemotherapy. And that's what I want to take you through, these chemotherapy that not the standard one where you give the drug in the vein or in the mouth. The drug goes all over the body, and when it counter cancer cell, by chance it kill cancer cell, but does a lot of abnormality and a lot of complication. And then we can finish with a couple of words on the gene therapy. This is very important, and this is where going to be the majority of the talk. This immune therapy. We do know that when the cell proliferate and when the mother cells goes into two cells, the human genome is so complex, so there will be a lot of mutation in the daughter cells. But we know the body is able, through these immune check mechanism with the T cell, to look to these abnormal mutation and try to take care of it, and cause like the cell which has abnormal mutation go into cell death. We call it apoptosis, and there is no problem. And when there is no good T cell natural killer to take care of these things, this is one of the reasons cancer happen. Then you have a mutated cell that goes into leukemia or carcinoma, what have you. So studying the immune cell, finding immune therapy is what changed the practice of oncology these days. And I'm going to start one by one and elaborate. So the first one, which is just from historical perspective, is gamma interferon, or we call it non-specific immune modulator, or we call it like biologic response modifier. We used it in the past. Nobody uses it right now to treat melanoma and hairy cell leukemia. What does gamma interferon do? It look into the immune cell like macrophage, dendritic cell, T cell, and activate them. And with this activation, it will work on boosting the immune system to attack the cancer cell. We know neuroblastoma is a very interesting cancer. Why is interesting cancer? Because neuroblastoma can go into self-maturation. We have, any cancer has stage 1, 2, 3, 4, but a neuroblastoma is so unique, it has a stage 4S. And we call it 4S because it's special. We have a newborn who are born with a stage 4S. We don't do anything for them. And then they mature on their own and the cancer go away. So from the beginning, and I used this probably 20 years ago, retinoic acid is a biologic response modifier. People use it recently for acne. And we knew at that time that we can use 13-cis retinoic acid for neuroblastoma. Right now, it's part of the maintenance of a neuroblastoma. The same thing, GM-CSF, granulocyte, macrophage, colony stimulating factor. These two are part of maintenance of a neuroblastoma. They work very well, and they are biological response modifiers. So we knew this a while back, but we know they are now part of the treatment. Let's move a little bit forward. This is IgG molecule, just to refresh your memory. And it's an antibody, and it has two portions, the Fc portion, and that's the portion that attached to macrophage. And this is the FAB, the antibody that attached to antigen. The main purpose of this, if you have a virus, bacteria, The IgG goes there, pick it up, take it to the macrophage or natural killer cell and kill it. And people start saying, maybe we can use this for cancer, and that's what we call it immune therapy. And just to give you an example on monoclonal antibody in cancer, the first one is Rituxan. You see these purple thing? This is rituximab. It is anti-CD20. B-cell lymphoma come from a B cell, and CD20 is on the B-cell lymphoma in 99% of the cases. So this is a rituximab engineer for the CD20. So when you give rituximab to patient with B-cell lymphoma, and right now Burkitt lymphoma, which is the most common in pediatric, rituximab is a standard there. And if you give it, what does it do? It has a different way of mechanism action. As soon as it does interact with the CD20, as you see, there is this area that can attack with the macrophage attack the B-cell lymphoma, or by itself, it can initiate direct apoptosis, direct cell death, or it can bring the natural killer cell. And I have a very interesting story on rituximab. In the 90s, I had a patient came, he was a teenager from Cayman Island, and he had large cell lymphoma. So I treated him at that time with a regular first-line chemotherapy. He did well, then he relapsed. I gave him a second line, then he relapsed again. So I know I'm dealing with a refractory large cell lymphoma. So I transplanted him. I did autologous transplant. After autologous transplant, the same thing. It was a year, and then he relapsed. Late 90s, we had rituximab FDA approved for refractory lymphoma. I gave him 6 courses of rituximab, and he's doing very well, and he's a long-term survival. So right now, rituximab is a great drug for lymphoma, and we use it up front and improve the survival of the patient. Another monoclonal antibody, and this is for a neuroblastoma. Neuroblastoma cell has a GD2 antigen, and there is a drug called dinutuximab or Neutuxin that has been engineered to attach to the GD2, and by attaching to the GD2 activated it will bring natural killer cell and lymphocyte and attack the neuroblastoma. And dinutuximab is right now a part of like standard treatment for chemotherapy. When I started in the 80s, stage 4 high-risk neuroblastoma was less than 20% survival. No child survived. Going forward right now, between the biologic response modifier, between the immune therapy, between the stem cell transplant, and we do all that, we save at least 50% of our patients. Of course, we're not there yet, but we made a big stride improvement, and this is based on the advancement in immune therapy. Another type of immune therapy called bispecific antibody. So you have the IgG here, and you have 2 sides. So people start thinking, maybe if we can engineer a specific antibody, so we can bring the cancer cell closely with the natural killer cell. And we have an amazing story with that, with blinatumomab. And this is just a fancy picture to see you have a cancer cell and you have the T cell, and to bring them. So blinatumomab is bispecific antibody, and we used it, I would say, between 2010 and 2015 for refractory acute lymphocytic leukemia. As you know, when you say the higher the percentage of curing, then the more the challenges. So if we in 2010 cure 80%, it was very, very difficult to cure the 20% that they relapse. And we started working on the refractory. We say it worked. Some of the patients do well. Till the Children Oncology Group, which is the largest group here in the United States, did upfront study to treat standard leukemia patient, and they did like not double blind, like randomized study. Half of the patient did not get a Blincyto, just regular treatment. The other half get a Blincyto blinatumomab. And the result was amazing. It was published in New England Journal of Medicine at the end of last year, and it showed that blinatumomab improved it from 80% to 90%, and now it's part of the upfront treatment of the children. Now we use chemotherapy and we use the bispecific antibody as a standard treatment because we don't want patient to relapse because it's hard to treat them. Now we go forward, another type of immunotherapy, it's an antibody drug conjugate or ADC. And what you do here, you have the IgG molecule that will attach to the cancer cell. And what you do with it, you link that IgG molecule that attached to the cancer cell with a poison. So that poison right now is not going to all over the body and cause a lot of problem, although it does have its a portfolio of side effect, but it's going to go specifically to the cancer cell and it's going to attack the cancer cell. And a very nice example on the ADC is brentuximab vedotin. So what you have here, you have the IgG molecule, which is anti-CD3. We know in Hodgkin lymphoma, they do have the CD30 antigen, and you have the linker, and you have the poison here, and the cytotoxic drug. So when you give it to the patient, it goes to the cancer cell and attack it. And it was, brentuximab has been used in the last few years for like stage 4 high-risk patient. It improves survival from 70% to 80%. And to go forward, we have another type of immune modulation called checkpoint inhibitor. And just to understand the immune system here, if our immune system does not have a checkpoint inhibitor, our immune system is going to go crazy and is going to attack our organ and cause autoimmune disease like lupus, arthritis, autoimmune hemolytic anemia. The checkpoint inhibitor in the immune system are made to keep our immune cells under control. And the tumor cell is basically, for its survival, it has to make sure that the natural, because each cell has to survive. And we go back to the biology and the paramecium cells. How do they survive? So cancer cells need to survive. And the way the cancer cell, when they go into the body, they inhibit the T cell, the natural killer cell. The tumor cell has a PD-L1 ligand, and the T cell has PD-1 ligand. When they get attached to each other, the tumor cell causes T cell apoptosis. So tumor cell here taking advantage of our immune system so it doesn't kill it, so it survives. And then at the end of the day, it kills the body and the patient basically pass away, expire. So people say, okay, can we do anything to these checkpoint inhibitor? And we have an amazing story. And I'm talking about pediatric here because adults used it in different cancer. Now, there is something called nivolumab. Nivolumab is a checkpoint inhibitor, and it has been used in adult and adolescent with Hodgkin lymphoma. And nivolumab was used with the brentuximab. This is the drug that I showed you just a couple of slides earlier. And people say maybe nivolumab will be better than brentuximab. And it was amazing that when we used nivolumab on 2 randomized trials, we saw the cure of stage 4 advanced Hodgkin lymphoma went up to 90%. So now nivolumab is part of our, let's say, army that we use and weapon that you use, and it's used for different type of cancer. In pediatric, we use it for Hodgkin lymphoma, and these are a checkpoint inhibitor. What else we have here? CAR T cell therapy. You know, when I first heard about CAR T cell, I said, oh my God, this is like Star Wars. I know a lot of you guys have seen the Star Wars. It's just crazy and amazing where technology got into sophistication and where it's helping back the human health. And the CAR T cell has different subtype, immune therapy. It harnesses the individual own immune system if you have problem with immune deficiency, cellular therapy, and this is what I'm going to explain right now, what we call the CAR T cell. And even and the cell therapy, they use individual own T cell. The gene therapy, they insert certain gene in the cell of the patient if the patient is deficient. Let's say like patient with hemophilia A, that doesn't make factor VIII, so you can make them use that. So let's start with the CAR T cell, and this is just a diagram we say. So we will start by taking the patient. This is a patient, let's say a child who has acute leukemia, and this is refractory. What do you do? So the first thing you want to do is you want to collect the T cells out of the child. So you're going to take these T cells back in vitro in the lab, and you're going to engineer it, because we know acute lymphocytic leukemia, it's CD19, like we spoke about the Blincyto, and you want to make sure that this now T cell is engineered to attack CD19 cell. And this is patient own cell. This is not like the foreign cell. And you put it in vitro and you grow it, and then you give the patient chemotherapy so you can kill all the cells that abnormal in the body, and you give the patient their own T cell, but now this is a T cell that is just armed to attack the leukemic cell. And there are a lot of trial FDA approved CAR T cell in pediatric AL, I think in 2017. And there is now like a different type of CAR T cell. A lot of pharmaceutical company are trying to create their own CAR T cell for leukemia, and we're using a different way. And it's not only for leukemia. There is a lot of study right now about CAR T cell even for solid tumor, for pediatric, and for adult. Of course, we are still in the A of A, B, C to Z in the CAR T cell, but imagine if we continue with the speed that we've been doing for the last 20, 30 years, how much we can gain information and how much we can achieve in the next 10 years with the CAR T cell. Moving forward, a new generation of chemotherapy is called targeted therapy. What do I mean with targeted therapy? Small molecules inhibitor. So these are a drug that they are small enough to go inside the cancer cell and block certain protein that tell cancer cell how to grow. We call it, there is a lot of different of something called signaling pathway. These are pathway that are normal in the cell, and they tell the cell when to proliferate, when not to proliferate. So when we learn about this pathway, we say, okay, why don't we do certain drug that inhibit? One of the pathway, which is very known, is tyrosine kinase pathway. And there is a lot of drugs under clinical studies. Mainly right now, we use it for pediatric, for like low-grade glioma or high-grade glioma, to use it, and it's used in a lot of other cancer in different ways. The same thing for mTOR inhibitor. Everolimus, we used it for patient who has DIPG and has other type of brain tumor. And so there is now a new area when if you have a certain pathway, you want to attack it, you want to stop it, and you can make the cancer cell stop. I want to spend a couple of minutes talking about a very close to my heart target therapy, and it's called ONC201. And the reason I'm doing this because we were Miami Cancer Institute, one of the first few center in 2017, 2018, where we opened phase 1, phase 2 trial. And this is mainly really for DIPG. DIPG is diffuse intrinsic pontine glioma. Although it's very rare, but it's a deadly disease, unfortunately. If a child get DIPG, the lifespan from diagnosis to death is 18 months, and it's still 18 months. And the unique thing about DIPG is over 90% of patient who has DIPG has a gene H3K27 mutated. We just spoke about the gene and how discovered. What is H3K27? H3K27 is a tumor suppressor gene. I didn't mention, as we're talking about the gene, we found that there is tumor suppressor gene and there is tumor simulating gene. So H3K27 is a normal gene in our body that suppresses tumor. But if it is mutated, like in 95% of patients with DIPG, then it is part of the making of the cancer, making of this high-grade glioma. So a pharmaceutical company find a drug and they called it ONC201. It has a different name too. And they said, okay, let's try it on children. The mechanism is, it's not only reverse the loss of H327, it always affects certain signaling pathway in the body and disrupt the growth of the cell. So we are at the stage right now that we hope that this year the FDA is going to approve H3K27, I'm sorry, the ONC201 to be used and by everybody, not only for a specific earlier trial, which means any researcher anywhere in this country can take this drug right now and add it to other drugs that we have against cancer. And I'm hoping, hopefully within 5 years, instead of say everybody is gonna die like we did for the leukemia in 1965, we're gonna start seeing 50% and 80% survival. So that's why it's so exciting, the oncology field these days. Now I'm gonna switch, it's almost 30 minutes. I'm gonna switch from oncology to say a few words about hematology. And I put hepcidin here because it's a very interesting molecule that we discovered relatively recently. And hepcidin is a molecule that negatively regulate iron. I want to talk about iron deficiency anemia, which is the most common anemia in pediatrics. And we learned over the year that iron is not only important for the anemia, iron in pediatric important for the brain maturation. So if your child has iron deficiency and you don't treat it, your child is not going to get the good IQ that inherited from you or from mom and dad. So what happened here is children who get hooked on the milk, they are 1 year, 2 years, and they don't want to eat anything else, and they drink milk. And we give them oral iron. Kids spit the oral iron. They don't like the oral iron. So what do? We had IV iron in the past, and this is where the segue out. But the IV iron was so complicated that we had to put the patient in the ICU, give them a skin dose of IV iron. Half of them react. We can give it to them. But nowadays, we have a big different molecules or compound of IV iron that is so safe that is very easy. We find a child who has severe iron deficiency. We give 4 weeks a trial of oral iron. If that doesn't work, boom, let's do IV iron, load them with iron, and then there will be no issue with the brain maturity or anything else. So right now, treating iron deficiency is much easier. The second thing I want to talk about iron deficiency, we always talk about iron deficiency anemia, but there are iron deficiency without anemia. So this is what we call it the pre-anemic stage. And the literature starts with athletic teenager who sometimes they feel like they are run out of energy, and these teenager really has issues with iron deficiency, not anemia yet. And this is mainly female who has menorrhagia because of hormonal changes for their age. So now we know, and the literature is very obvious, that if you give IV iron or oral iron to these pre-iron deficiency, they get back their energy, they get back their activity. And I don't know if you know this sad story. There is a guy named Armstrong who won, I think it was the French Alp biking for years and years. And it turned out to be after that he's a scammer. And what he used to do, when they give them a break in the Alps and to eat or do what, the guy just lay down and they give him like a big unit of packed red blood cells. So they increase his hemoglobin from 14, 15 up to 17, 18. So he get back on his bike. Now he has more blood in his body. It doesn't matter the oxygen is low in the Alp. He can still compete and win the medal. So it's very obvious that iron is important to give you good energy to have basically normal life. And this is something recent we learned of. Moving forward, hemophilia, my God, when I started hemophilia in the 80s, patients used to die with HIV infection. And I think, I don't know, I mean, Arthur Ashe is one of the story that we have, that he got a blood transfusion for whatever it has HIV and he passed away. So these patients with hemophilia, I felt sorry for them. Initially, they were dying with with HIV, and then if they're not dying with HIV, they have a lot of a problem with joint bleeding, and we give them factor 8, and their life is not normal because they have to inject them every time. You don't have an IV on them. Some of them develop inhibitor. Just to make long story short, now there is a new era of hemophilia treatment that is totally different what I experienced in that 30 years. Now we call them non-factor replacement. So what's the idea here? So in general, you want activated factor 8 to activate, I'm sorry, this is factor 9. Activated factor 9 will activate factor 8 to activate factor 10. So at the end, to initiate the cascade, you need factor 10 activated. And hemophilia, severe hemophilia A or B, but Hemlibra is for A, they cannot activate factor 10. So this is monoclonal antibody. This is just, it's called emicizumab, has nothing to do with factor. And when you give it to the patient, it was engineered, it doesn't bring activated factor 9 to factor 10. And boom, you initiate the cascade. It's amazing. It's sub-Q injection. Now, like a few years ago, I used to put infuser port and learn the family how to do the port. Now it's like insulin injection. You have a severe hemophilia, no problem, no sweat. We do sub-Q injection once a week for 4 weeks, and then once every hour, and then once a month. So these people have a normal life with sub-Q injection with no problem. It's amazing. We go forward here. There is something now called Altuvio. This is basically a factor 8 that has been modulated to stay longer. Half-life of factor 8 is 12 hours. Altuvio, with all these modifications that you see on the screen, it's there for 40 hours. Severe hemophilia has less than 1% factor 8. All what you need to do is get factor 8 to up to 10%, 20%, and the patient has no problem. So one injection of Altuvio once a week make everything is good. So welcome to the new era of hemophilia treatment. I think we're closing here. Just gene therapy, there are probably, I don't know, maybe 40 some clinical trial right now in this country about doing gene therapy in different places. Hemophilia A, inherited retinal disorder, for muscular dystrophy, and recently for sickle cell disease. I mean, this is really something amazing that the door we are opening. It's still a research trial. Right now, it costs $2 million. I'm sure as technology improved, it's going to cost a little bit later, as the federal government had to pay for gene sequencing and mapping, and now $2,000 you can map your own genome. So we're heading in the right direction. And all what you need to do, if you have a child with sickle cell born, okay, let's do gene therapy, and then we will get rid of sickle cell disease like we got rid of, smallpox and other diseases. And we spoke about CAR T cell therapy. Okay, so talking about cancer survival, we're learning a lot about, as we have more children surviving cancer, we're discovering the long-term effect, long side effect of chemotherapy. For a long time, when I sit with the family who I diagnosed with cancer, I tell them, I'm sorry, I have to give your child a poison. I need to poison your child to cure your child. We call it chemotherapy in medicine because we don't like to tell you we are governing, but it's a poison. So what does that poison cause? We are so good, we feel good right now. 85% of our children are cancer survivor. It's amazing. People ask me, even doctors in the doctor field, they say, oh my God, Dr. D, we don't know how do you do it. Well, when you cure 85% of your patient, it's an amazing, gratifying things. So yes, pediatric oncology is an amazing field because you cure 85% of your patient in 2025. There is a price for that because we used all these poison over the years. Now we have to deal with long-term complication. I remember in 2010, they said that one out of 1,000 of 18 years old in this country was a long-term survival, and I'm sure it is more than one right now. but these people go around and they have problem. 100% of long-term survival has a problem with anxiety. So although we cure them, but they have an issue and they need a lot of support. Uh, and that's why these patients, we create the long-term survival clinic for them. And so our psychologists can support them, can help them. And other problem that we do have issues with bone density. We do bone density on them. We give them vitamin D. Heart was big problem because anthracycline, as you know, cause heart failure. Now we have a drug that we give the patient prior of giving the doxorubicin. It's called Zinacard, and it prevent the heart failure. But although we give the drug, we still need to do echocardiogram on them. And some of the patient, I tell them every other year or every 5 years for the rest of your life, you need to check on your heart. And we have now a new specialty. It's called cardio oncologist. These are cardiac specialists that specialize only in patients that that took cancer drug before, to make sure that you discover early the heart failure and then you treat it. And I know over the years, unfortunately, we lost patients who basically died on treatment because of heart failure, because of our poison that we give them. Lung bleomycin cause problem with lung failure. And I told you about brentuximab and about the nivolumab. Our protocol a few years ago, when it got put together, they got rid of the bleomycin. So now these drugs not only increasing survival, but trying to protect all these problems. Secondary malignancy is rare, but it's there, doesn't go anywhere. Fertility is a major thing. Right now, all our patients get the chance to say, if a male, you want to do sperm banking. If a female, it's much more complicated, but there is a lot of research on trying to say how you can save the ovary, how you can take a little bit of biopsy, put it in the freezer. So when the female wants her own eggs, she can get it back and she can have her own babies. But this is still in the early step. And last but not least, I want to say a couple of words about proton. This is the one before my last slide. I think I'm on time. Proton treatment is just an amazing treatment. It's a new type of radiation therapy. And it is amazing because it has an ability to precisely target a tumor while sparing surrounding healthy tissues. And we're so fortunate at Miami Cancer Institute. We really have the largest proton therapy center in like south of Florida, or the half of Florida here, and we get kids from all over the world. And why it's important? Because this is child, and mainly for brain tumor. So you have a child, you have a brain that is so immature and wants to grow, and you give that, frying, we call it, frying. How do you treat cancer? You either cut it, do surgery, or you poison it by chemotherapy, or you fry it by radiation therapy. And the reason for you say frying, because it does affect the other normal tissue. But the proton therapy is so amazing because it reduces damage to the healthy tissue, because it's only in that area. And it lower radiation exposure, and it's improve quality of life. So although it's not a new treatment, but it's a treatment that has a better efficiency, and it has less side effect. And there is no child in this country right now who has a brain tumor and get regular photon treatment. It has to be proton, basically. And the last slide, talking about AYA. AYA is adolescent and young adult, and there is a lot of interest right now in this country in this group of patients, because not all cancer cell in the same, in different group is the same. And I used to give the example before. I used to say, like, I'm 68-year-old right now. If I get acute leukemia right now, maybe my chance of survival 50-50. If a child get acute leukemia, it's the same cancer cell, the child is 90%. So why is that? I'm sure over each age has probably different mutation, different things. So there is a lot of study done right now on the adolescent and young adult. This is age 15 up to 26, maybe long, maybe higher, to see if you can take these group and try to tailor to them a treatment and support, and hopefully if they have complication, other things. So at this stage, Dr. Hakim, I would stop and I'll stop the sharing basically.
Dr. Daghistani, I am in awe of how you captured every step of the way since 1965 with that film that you watched to date. I mean, you can write a book on your own in regards to hematology and oncology and how fast the field of hematology and oncology have evolved in front of your eyes year after year. As a matter of fact, day after day, you're seeing things that are absolutely mind boggling. So, congratulations. You did say it well. We're very fortunate to have Miami Cancer Institute, but I think we're more fortunate to have a scientist like yourself that can actually help us fight this horrendous disease that hinders the lives of so many children and the ones that you see on a daily basis. So, thank you for everything you do. You mentioned something that is perhaps one of the pearls this afternoon, and it was the fact that you reminded us that back in 1990 was a breakthrough moment with genome sequencing. Wow, what an awakening in medicine for us to have something that was absolutely mind-boggling or not understood. And now, for us to be able, each one of us, if we can, to actually have our own sequencing, it is mind boggling in itself. But more importantly, what it's done to science, what it's done to oncology, what it's done in your field is absolutely magnificent. Many things to take on, many important things that we should highlight, and you're absolutely right. Some of the stuff are Star Wars kind of thing. I love the CAR T cell. Still is a to all physicians that are not in oncology is still something that is mind-boggling. I mean, we trust you, we know that you're doing it, but we still cannot necessarily understand how you can actually re-engineer a simple T cell to be able to attack a leukemic cell. That in itself is absolutely incredible. But I wanted to also highlight the fact that there are multiple types of CAR T cell. Can you elaborate a little more on that just simply put how it is that you decide that there is a specific CAR T cell for specific individuals?
Right. So when CAR T cell started looking into solid tumor and leukemic cell, and initially, let's say in solid tumor, and they started at the NIH. Let's say you have a melanoma, they take your melanoma cell, they take your T cell, and in vitro they sensitize your T cell against the melanoma, and they give you your T cell back synthesized against your T cell. But that will be done on individual. Now, because the leukemic cell has a certain, like let's say, common share antigen, you can engineer a drug. And one company started now, I think we have 4 companies have 4 different T cell against the CD19. And is there a difference between them? I think time will tell. So you can give them to the patient and they already sensitized the CD19. And even for DIPG, there are a few centers that they're looking into CAR T cell in DIPG and doing. Some of them probably will not have a positive thing, but even if 1 out of 10 clinical trials showed advancement, we have a major step forward. So it is still in its incubation period, but I think it's going forward.
Absolutely, and we have seen that, especially at our center, Miami Cancer Institute. The IPG has been obviously a focus and strategy for you, and our doctors managing the ONC trials, especially 201 for pediatric DIPG. And I think it is a good parenthesis to make and share with our peers abroad. that we have an average of a given month or a given quarter, we have an average of 300 and plus clinical trials in multiple specialties, in one of which the most used clinical trial now to date, known to date, is the ONC trial. So we do receive a lot of patients, and Dr. Daghistani has been amazing at helping us transition these babies or these kids from many parts of the world, simply because the pharmaceutical company has positioned us and helped us in putting the DIPG treatments in our center. Can you talk to us a little bit about the selection process of this particular clinical trial, especially for DIPG?
Right. So when we started, really, we started as phase one trial. We didn't know what is the maximum dose tolerated in children, and I was amazed how well children tolerated the ONC201. It's a oral medication, liquid or tablet, that's given once a week to the children. And the selection process, initially, we did have a clinical trial for the DIPG and for other, we call it mid-thalamic disease. And we did find that in the midbrain, or the thalamus, has in general a better response. So the company decided to do a double-blind study.
Mm.
This is the action study you mentioned. So, but this is stopped right now in the United States. And we do have now one trial called the compassionate use of the IPG.
Mhm.
So if your child have a DIPG and you're desperate and you want to do something, you can come to us and we can say, as long as your child receive just radiation therapy, which is the common treatment, we are more than happy to give you this medication. And over the years, we collected a lot of data in our center and other center. And the pharmaceutical company felt so good about it. They put all these data together, and they are all hoping that the FDA is going to approve that. And this is the major step where you make this drug available to all researchers over the country. And then this is how you start the first mile in 1,000-mile road to cure the IPG.
Mm-hmm. And it is just mind-boggling that we used to put diseases such as hemophilia, as you mentioned not long ago, and then now put them in almost a category that we don't necessarily have to worry about, where hemophilia in the past was a major component of physicians' practice, especially in hematology in some countries. And now for them to receive a sub-Q injection and click and move on with their lives, to the fact that now we have these targeted therapies, and especially these clinical trials that potentially will open the doors for many cures in the future. So it is impressive, honestly. But I think that you left us with a better flavor in our mouth, obviously, because every time we hear about a baby or a kid that has suffered either from Burkitt's lymphoma, which is definitely one of the most aggressive cancers that we know, at least in internal medicine, that we refer to you guys, for it to be now considered perhaps a condition that we can eventually treat more actively. You did mention, though, that all this is opening the doors not only for the types of tumors or types of neoplasms that you're talked about, but maybe in the future for solid tumors. Which is a solid tumor that you're excited about that perhaps is going to have the first right of refusal as a treatment?
Always you look into what are the disease that's still hard to cure. And the first thing come to my mind is sarcoma in pediatric.
Oh my goodness, yes.
Uh, Over the 20, actually over the 30 years in my practice, I mean, we have not made any strides in metastatic sarcoma,
Right.
either bone sarcoma or rhabdomyosarcoma. So to me, this is the place where we really need to focus and try to see. We need to understand more. We have all these new drug and try to see if we can use them Of course, on top of the IPG, because nobody survived, this is the area where I'm hoping before I leave my practice in a few years, I'll see some stride and some improvement in it.
Well, we're not hoping for you to leave your practice. You're going to be with us for a long, long time because these discoveries will be available for you to help us treat our kids. Gene therapy, hemophilia A, inherited retinal disorders, spinal muscular atrophy, sickle cell disease, CAR T cell therapy. Oh my God, the armamentarium that you have currently with this mind-boggling pharmacopoeia is just absolutely phenomenal. But you left us with one statistic, and it's 85% of children are cancer survivors. And that is like a wow, 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 because this kind of conversation we would not have had, obviously, in 1965, but much less in the mid 90s, and now, obviously, in the early 2000s. And for you to share with us that it's 85%, it's just, it gives us hope that these side effects that you mentioned at the end are just, you know what, we'll deal with it. Psychological, hard, long, whatever. As long as a baby is becomes an adult, you know, that's what we all care for. But the way you guys treat cancer and the Miami Cancer Institute, it is perhaps one thing that we should highlight as a final word, and it's the fact that you have an interdisciplinary approach to every patient that comes into your office. So you're not working alone. You are working with psychologists, you're working with cardiologists, you're working with all kinds of specialists in order for you to address the entire gamut of potential side effects. So, with that, Doctor, any final thoughts in regards to how excited you might be about a technology or something that is coming your way?
I think the word to take home is never lose hope. As long as we have hope in our heart, we're going to get one day to cancer is like a flu. You can take just a vaccine or what have you and go on with your life, God willing.
May God continue listening to you and give you strength to continue fighting this fight. Thank you so very much, Dr. Daghistani. I want to thank you on behalf of our international team for always being so helpful to us and for your partnership. And of course, to everybody that participated today for your attendance and for your attention to this magnificent lecture. If you have additional questions about today's presentation from Dr. Daghistani, or if you have a concern about a particular case that you're managing in your own countries that you would like for Dr. Daghistani to look into, please do not forget to email us at BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will make sure to attend to your email and forward it to Dr. Daghistani for his consideration and evaluation. We look forward to seeing you all in our next oncology lecture series, which is scheduled for Wednesday, July 16th, 2025. So thank you once again and have a great afternoon. Dr. Daghistani, a virtual hug to you. Thank you so much for everything that you do.
Thank you. I appreciate your help. Have a good day, guys.
Thank you. Goodbye.